خير ان شاء الله.
ممكن تتفضل تبدا على طول عشان الساعه 9 بالظبط يا كريم. احنا ممكن نعمل تشير بقى زي ما انت عارف كده هو، وكلنا معاك.
حضرتك شايف السكرين؟
not yet.
لا لسه. لسه الزرار الاخضر زي ما قلت لك كده كده، الزرار الاخضر في النص اللي تحت.
ده حضرتك شايف سلايد اونلي.
كده تمام كده كويس قوي. اتفضل يا كريم انت خلاص كده.
So, good evening everyone, dear Professor and colleagues. I am Karim ElChilali from cardiovascular medicine and cardiovascular and respiratory medicine department of House in Germany. Thanks for kind invitation from Professor Dr. Muhammad Abdul Ghani. I am able to join you in this great scientific meeting and have the privilege to talk with my professors and colleagues in Cairo about aortic stenosis, recent updates in aortic stenosis. My presentation will be a trial to summarize the new data emerging from studies published in 2019 and 2020 regarding the management of aortic stenosis. As we all know, degenerative aortic stenosis is a progressive disease that after decades of latency characterized by progressive calcification, progressive thickening, and restriction of mobility of aortic valve leaflet till the mechanics of the aortic valve is severely affected and the patient becomes to be symptomatic. Once the patient has severe aortic stenosis and becomes symptomatic, the survival will be and quality of life will be affected, and unless a treatment timely done is unless the treatment timely is performed, my English is very bad. Survival will be affected. Decreased survival in after onset of symptoms is awaited. In my presentation, I would like to touch on 3 points. The first one is how should we treat aortic stenosis. The second one, if we choose TAVI for treatment, which device would be on our choice. And the third one, when actually should we actively treat aortic stenosis. I will start with first points. The latest version of European guidelines states that the major decision-making points in treating aortic stenosis is severity of the disease. Once the disease is severe, the second point is to look if the patient is symptomatic or not. And symptomatic patients, when we are expected to have a decent survival, that they don't have comorbidities that make prognosis bad apart from severe aortic stenosis, they should undergo aortic valve replacement. This aortic valve replacement to do comes the next step is to look at the expected surgical risk of these patients. And according to models we have for risk stratifications of these patients, they can be categorized into low-risk patients, as low expected mortality and morbidity after aortic valve replacement, intermediate risk or high-risk patients. And the guidelines say that low-risk patients should directly go to surgical aortic valve replacement, while intermediate and high surgical risk patients, they should be seen in heart team, and decision should be made if they undergo surgical replacement with the aortic valve or undergo a transcatheter repair of the valve known as TAVI. There's criteria that favors TAVI in this patient, criteria that favors aortic valve replacement, but basically the guidelines latest version which we have says that aortic valve replacement is +1 indication in all risk categories of aortic stenosis, and TAVI is an alternative treatment in patients with intermediate or high surgical risk according to consensus for local heart team at the center which do the procedure. When the guidelines was issued for 2017, we had no data about TAVI outcomes in patients with low risk aortic stenosis, but the TAVI data in patients with high risk and intermediate risk, which both showed non-inferiority of the TAVI in this risk categories of patients compared to surgical aortic valve replacement, encouraged researchers to explore further what if we perform the procedure at patients with low surgical risk. 12 months ago, the New England Journal of Medicine in the same issue have published 2 trials comparing the outcomes of aortic valve replacement, surgical aortic valve replacement, and TAVI in patients with low surgical risk. The first one was the Partner 3 trial. In this trial, patients were randomized in 1-to-1 fashion to patients with severe symptomatic aortic stenosis, were randomized to 1-to-1 fashion, either to receive a surgical aortic valve replacement or to receive a transcatheter aortic valve replacement with SAPIEN 3 or SAPIEN 3 Ultra balloon-expandable prosthesis. The primary outcome of the trial was a composite of death from any cause, of all-cause mortality or stroke or rehospitalization 1 year after the procedure. The trial included about 1,000 patients. Lastly, 496 patients have undergone TAVI, and 454 patients have undergone surgical valve replacement. Baseline characteristics of the patient show that in comparison to our earlier TAVI trial, the patients were about a decade younger than every TAVI trial which have previously seen. As the average age of patients in TAVI registries, TAVI trial was 82 years in average. In Partner 3, we see for first time patients with average age of about 73, 74 years. Otherwise, both sexes were equal, was represented, but also in comparison to all the trials, the male predominance here was apparent. Otherwise, when we compare to our own TAVI data, it will be like equal male-female ratio or sometimes more females. I think it can be explained by relatively younger age of patients in this low-risk trial. We have been talking about low risk, intermediate risk, high risk. The risk is generally calculated with one of established risk scores, mostly the STS score or Society of Thoracic Surgeons score. It's online-based calculator. About 41 parameters will be entered in this calculator before considering patient for surgery. And according to established regression model, the risk score calculator calculates the expected 30-day mortality of the patient if he undergoes surgery. And it's agreed upon that the patient was expected 30-day mortality from 4% or less are considered low-risk patients. 4 to 8% according to STS score are intermediate risk, and about 8% expected mortality at 30 days are high risk patients. Euroscore is similar score, has a little bit different cutoff points, but we can roughly say, I am speaking now about Euroscore 2, this is modified Euroscore, modified logistic Euroscore. STS score is much more widely distributed. Euroscore takes cutoff points like lower than 5%, 10%, and above 10%. If we see the characteristics of this patient, they were low-risk patients with 2% expected mortality in both groups. There was no frail patients in the study, and about the aortic valve parameters, they are similar to all to our own study. Although all patients had aortic valve area lower than 1 square centimeter, mean gradient above 40, ejection fraction was normal in this case. SAPIEN 3 prosthesis is required, as the study is financed or sponsored from the Edwards, the company making SAPIEN prosthesis, and CT measurements are prerequisite in sizing of the prosthesis, and they included the CT measurements. It's important only to know that every patient in this trial of undergone surgery or aortic valve replacement was a prerequisite that they are candidates for both procedures. That it means from clinical point of view and from feasibility view that either procedure could be performed in every patient, and this is why they included the CT parameters, which shows that the patients were similar. The composite endpoint was all-cause death, stroke, or rehospitalization at 1 year. And at 12 months, it was evident that the patient who undergone TAVI had superior outcome to surgery. The trial have shown superiority of TAVI to surgery in low-risk patients with isolated aortic stenosis. The composite endpoint in TAVI group at 1 year was 8.5% and about double as 15% in surgery patients. The secondary analysis included the isolated outcomes of the composite endpoint, and in every for these isolated outcomes, TAVI has performed better as in regard surgery. It did not reach statistical significance in every point, but the tendency to better outcome was evident. The hazard ratio for death mortality was 1%. Mortality at 1 year in low risk was 1% in TAVI, 2.5% in surgery. Hazard ratio 0.4 did not reach statistical significance, but trend was there. Stroke was also trend to lower stroke risk by TAVI patients, and hospitalization was also lower as rehospitalization after procedure at 12 months were lower at TAVI. This forest diagram showed subgroup analysis from this trial. They took relatively young patients, less than 74 years, more than 74 years. 74 was chosen because it was the mean age of participants in the trial. The two sex different, gender, male, female. Lower is anyway. All patients had low STS score that is lower than 2 or higher than 2. I don't think it makes big difference. But after all subgroup analyses were in the same direction. We didn't see much heterogeneity in the study outcome. it seems like it's class effect, or it seems like the procedure effect, and that there is no much interaction between patient characteristics and outcome in the trial. The authors of the trial concluded that TAVI in patients with low risk patients at surgery, the TAVI with SAPIENT 3 was superior to surgery in terms of composite endpoint on all-cause death, rehospitalization, and stroke at 1 year. Notably to say that all patients have undergone TAVI through transfemoral access. This was prerequisite in this trial. In the same issue came the outcome of TAVI using the self-expandable evolute prosthesis, the latest generation of Medtronic 4-valve prosthesis with surgery in low-risk patients. The TAVI, the study was also prospective multi-center 1-to-1 randomized trial with primary endpoint combined all-cause mortality or disabling stroke at 24 months or at follow-up till 24 months. I will touch on this point lately. And there was secondary endpoints like composite of deaths, disabling stroke, bleeding, vascular complications, and valve thrombosis, valve dysfunction, life-threatening bleeding, which are all safety endpoints as detailed in VARC criteria. Like the first trial, showed much younger patients than what we expect in other TAVI trials, which could be good explained by low risk of these patients. Females were also only one-third of patients were females, and all had severe aortic valve stenosis. The study compared 700 patients, about 700 patients in each group who undergone TAVI or surgery. Planned follow-up was up to 2 years. The study reported outcome once 850 patients reached 12 months follow-up or completed 12-month follow-up. They report the outcome at 2 years. They used a statistical model that it allows the investigator, once they completed the follow-up in 850 patients, to calculate the outcome or calculate the expected outcome at 2 years. And what they report here is their expected 24 months outcome TAVI against aortic valve replacement based on data analysis at 12 months of their first 850 patients. They used here Bayesian statistical model. They set their non-inferiority margin, and based on this statistical model, if the non-inferiority margin, if the TAVI outcome performed didn't cross this non-inferiority margin, then its non-inferiority was to be proved. If non-inferiority was proved, they had tested every secondary outcome endpoint, and only if non-inferiority for every secondary outcome endpoint could be met, they would have been tested for superiority. What they show in their analysis that TAVI was not inferior to surgery at 12 months follow-up. The expected combined outcome for disabling stroke and death at 24 months was made in 5% of TAVI patients, against about 6.7% in surgery patients. The set margin from the Bayesian confidence interval was set to be lower than 0.984. What they got much lower confidence, Bayesian confidence probability, and they could meet the primary endpoint, the non-inferiority could be met. Nevertheless, in the secondary endpoints, the non-inferiority was not met in every single endpoint, so they did not test for superiority. Their conclusion is that TAVI with self-expandable prosthesis was non-inferior to surgery in patients with severe symptomatic aortic stenosis who consider low risk at low surgical risk. Patients with who undergone TAVI with evolute prosthesis at 2 years or 1 year follow-up, throughout the follow-up period, had higher valve orifice area, had lower gradients. This is not a new finding. Although this finding we will see in every TAVI trial which uses self-expandable prosthesis. Self-expandable prosthesis are supraannular in nature, and they always have a very good orifice area and low gradient follow-up, which seems to be stable and don't follow-up. More pacemaker implantations, nevertheless, more pacemaker implantations in TAVI group in these patients, more paravalvular bleeds, which is also not surprising. Now, with completion of these two trials, we have randomized trials comparing surgery and TAVI across the whole spectrum of surgical risk in severe aortic stenosis. That stimulated researchers to perform a meta-analysis, including all TAVI trials which we have, all prospective trials, and compare the outcome of surgery, TAVI, across the whole spectrum of aortic stenosis. This is very interesting because if we look at every trial, we see that primary endpoint is always a composite endpoint. This has to do with feasibility of the trial. It will be very interesting to know what is the outcome in all-cause mortality, TAVI, aortic valve stenosis. What is the effect on all-cause mortality? Would need a large number of patients, much more time or much more investment in trial to meet the statistical power need to power the trial to test every endpoint separately. In meta-analysis, when adding patients from various trials, we could draw conclusion that shows the direction. What about all-cause mortality benefit? What about rehospitalization benefit? What about stroke incidence? What we could note with high certainty from single trial, withdraw high certainty from single trial. In their meta-analysis, they include 7 randomized trials, included 8,000 patients, 4,000 in TAVI group, 4,000 in surgical aortic stenosis. These are 2 trials in high-risk patients, the partner 1 trial and core valve high-risk trial. They had 2 trials in intermediate risk group, partner 2A and TAVI trial, also core valve and TAVI core valve on partner 2 Edwards XT. And they included 3 low-risk trials, the 2 we just mentioned, and Notion trial, a small trial run in Denmark in last year. They made their primary outcome was all-cause mortality, and the forest diagram, which was published as take-home message from this interesting meta-analysis, showed that the trend in every trial showed the trend that TAVI was superior in outcome relative to surgery in all-cause mortality. If we look at confidence intervals for each single trial. They did not reach these confidence intervals. They did not reach statistical significance, and this is because neither from these trials was powered enough to show mortality benefit. But if we combine the data coming from these trials, from all trials, we have a mortality benefit of hazard risk 0.12 in for 0.12 hazard risk, less hazard risk for TAVI for all-cause mortality in a follow-up that extends up to 2 years. From this 4,000 patients included in this analysis who underwent TAVI, about 3,600 had TAVI through transfemoral route. And in a sub-analysis, including only these patients, they had even more survival benefit. Here, hazard ratio was minimized by 17%, to say that TAVI was in this food meta-analysis was superior to surgery when transfemoral route was used. In the 400 patients who undergone TAVI through other routes, transapical, so there was no mortality benefit. In the second endpoints, TAVI was superior also in terms of incidence of stroke up to years, incidence of new onset of atrial fibrillation was less with TAVI, but surgery was better in regard to pacemaker implantations, but especially when self-expandable prosthesis was used. Surgery was marginally better than balloon-expandable prosthesis in regard to pacemaker implantation, but much more better than balloon-expandable in this regard. Bleeding complications were more with surgery, vascular complications was more with TAVI. What they did not, they could not, would be interesting, incidence of aortic regurg was slightly differently defined in various trials, and they could not perform this analysis. But nevertheless, the researchers, after getting this result, they concluded that the guidelines, 2017 guidelines that we have, need to be modified. They see that the final step of algorithm guidelines, which decides which way the patient should be behandled and should be treated with severe aortic stenosis, symptomatic, is this last step should be omitted. We don't need to calculate surgical risk score because, according to this data, there is no consequence. That is better all the way. The author suggests that for elderly patients, TAVI should be the new and the first option treatment, and only patients who get complex anatomy, who have other indications for surgery, like complex coronary artery disease, aortic aneurysm, non-feasibility of TAVI according to vascular access problems, and such like this, they should be considered for surgery. Otherwise, all patients who are older, according to the authors, all patients who are older 65 years should be first considered for TAVI. This is what the researchers concluded their meta-analysis. How does it look in real life? It's different from country to country, but in countries like Germany, where TAVI is much liberally done, much more. We do too much. We do much TAVI. And there was a consensus after publishing of low-risk TAVI trials, data from low-risk TAVI trials, and these data, there was a consensus document released from director of cardiovascular and cardiovascular surgery department of the German hospital. Matrix, as a decision-taking matrix, how would we treat patients with severe aortic stenosis? What is our decision-making strategy in this patient? The document was released in 2019 and was published in January this year. And I don't see the color code, but I believe you see the codes for these colors in this matrix: blue, light blue, green, light green, and yellow. Basically, blue TAVI is TAVI color. And whenever you meet blue color, it means my choice is TAVI, transfemoral TAVI. And the green color is surgery. Light blue would be TAVI or surgery, but TAVI is first, and TAVI is my first option. If not feasible or if refused, then surgery. Likewise, is for light green. Light green is transapical TAVI is the first option, when not is surgery. And yellow, it should be decided. Either way is okay. It's heart team and patient disease. What we see here, that the patients are divided into high risk, intermediate risk, low risk. Has nothing to do with final decision. The final decision is has nothing to do in final decision in patients older than 75 years. And all patients older than 85 years are candidates for therapy. All patients from 80 to 85 years are candidates for TAVI, whether they high or intermediate risk. Low risk patients, this is very extremely rare to have a patient older than 80 years and is low risk. It happens, that's rare. But even in this low risk patient, TAVI should be the first option. Surgery if the heart team consensus and patient will is to do surgery, or if other symptomatic indication for surgery like only RCT, although the patient would not be a low risk patient. In age group over 75 years, intermediate risk or high risk is the TAVI is first choice. In low risk patients, based on 2 trials which show that TAVI is not inferior, it's a heart team decision, is they gave equal weight for both procedures. The same goes for patient group over 70 and 65 to 70 years, TAVI to be considered in high risk patients. Surgery is, they prefer surgery in low risk and intermediate risk, transapical TAVI, or as TAVI or surgery should be nicht transapical TAVI. TAVI or surgery, surgery is first option, but TAVI is possible. Short saying, the new trend in Germany is above 70 years, severe symptomatic aortic stenosis will be treated primarily with transfemoral TAVI. Surgery will be considered in patients where TAVI is not feasible, or if the patient explicitly prefers to do surgery or consensus of heart team that there is another indication to do surgery in this patient. In patients 56 to 70 years, still the surgery is the preferred therapy in those patients. When there is contraindication to surgery, and these are not uncommon, there are patients who are low risk surgery but have tumors were irradiated previously, had advanced pulmonary disease, making anesthesia, intubation anesthesia, not much a comfortable option for their have porcelain aorta, as TAVI comes as preferred therapy in patients with characteristic making surgery outcome not much more good. Who undergoes surgery? When I see this diagram, the patients above 65 who have contraindications to TAVI, and patients younger than 65 years. It is not said loud, but it seems that we are going in the direction that the gold standard changes, and that in our populations that are increasingly aging population with extremes of age being more common frequent, that the new gold standard for therapy treatment of symptomatic degenerative severe aortic valve stenosis in the near future would be transfemoral aortic valve replacement or transfemoral aortic valve implantation, and the surgery, the old gold standard, will be a second option in patients who are some way not good candidates for transfemoral therapy. This is a consensus document, but how does it look like in reality? Professor Merman have published analysis of country-based data analysis in Germany. Germany data analysis for aortic valve replacement from 2012, the year where the first version of European guidelines was issued that made TAVI as a viable option for treatment of patients with severe aortic stenosis who are at high or prohibitive risk on surgery. He started his analysis from that year and till 2018. 2018 actually was before the publication of low-risk data, trial data, before the publication of data of partner 3. The trend, the trials, the TAVI low-risk trials were still ongoing at this time, but it was not secret. Analysis was not done, but it was apparent that that TAVI will do noteworthy surgery in these trials. In their analysis, we can see that surgical aortic valve replacement across the years had stable numbers. So about 9,000 patients per year will have a surgical aortic valve replacement all over Germany. TAVI transfemoral is in red, transapical is in green. One can see that over a period of 6 years, from 6,000 patients per year to 19,000 patients per year in 2018 had TAVI in Germany. A number that was lower than, initially lower than yearly patients who undergo surgery, it's now being ratio to 3:1. Every 4 patients who undergo aortic valve replacement in Germany, will 2 patients will undergo TAVI, and only 1 patient will undergo surgical aortic valve replacement. The transapical route did not grow in number, according to data which emerged from 2014 to 2015. That the transfemoral shows better outcomes than other forms of transvascular routes. The transapical route became a backup procedure when transfemoral is not feasible. Then we look if transapical is okay, then do it transapical. When transapical is also will be not so much doable, and or if surgical risk is accepted, we could do also a classical aortic valve replacement. With this increasing numbers of TAVI procedures, we see that the mortality was across the years was lower. The lower mortality in TAVI across the years can be explained better technologies. So the valves we are implanted in 2020 are not the ones we had in 2012. The valve itself, the prosthesis itself, regardless of which prosthesis we are talking about, we have better understanding what are the problems you are facing when we implant prosthesis. We have better understanding of the importance of paravalvular leads. The prosthesis in design and function are so designed that minimize the probability of incidence of paravalvular leaks, that they do a better sealing of the aortic annulus. The delivery systems are being more controllable, they're being lower in profile, management of bus. We understand that everything can go very well open at the level of the aortic valve, and because of vascular complication and access site, patients may become a worse outcome. The management of vascular access complications, the dealing with navigation of tortuous and calcified vessels, we have better understanding of that. We have also lower risk patients. We started in 2012 or before 2012 with patients with prohibitive risk, patients with high surgical risk. Slowly over the years, we become lower risk patients. As this surgical risk is calculated for surgery, it's not calculated for therapy. Nevertheless, various studies, observational studies, have shown that patients with high surgical risk and patients with lower risks, they have also different outcomes when they undergo TAVI. The patients with lower STS score, lower Euro score, they perform better than those with higher scores also when they undergo TAVI. And this can be explained simply because the patients who are considered high surgical risk are also PICA patients. They have not only our severe aortic stenosis, they have not only a valve problem, they have so many comorbidities that may affect outcome. If you do your procedure in a less invasive way, you probably end with better result. Nevertheless, the comorbidities still play a role. So mortality in TAVI are over the years is decreasing because of other quality of patients. We have this high risk patient, and we have also lower risk patients. We have better valve technology. Contrary, in surgery, when we took data for surgery, they are stable over the years. Mortality 3% all over the years. It's not much is changing, but it's also expected. Because the quality of patients, as the patient who undergo surgery, did not much change over the years. Surgery is an established procedure through decades. It's very unlikely that something happens in 3-4 years that dramatically change outcome in the procedure, which have been successfully done in 40 or 50 years till now. The transapical TAVI also shows stable outcome since 2014. Initially, where the outcome a little bit more in hospital mortality, about these are the initial years of experience. Then the procedure is held as backup procedure. The procedure is done, transapical is done basically by surgeon. And let's at the end, when surgeon decides I do transapical TAVI or I do surgery, I think the decision making makes the outcome also balanced. Because when the surgeon considers that transapical would be done, would not be feasible, he may take another way or may do open surgery. When he says that open surgery is risky, he'll make transapical TAVI, the outcomes are stable. This regarding how we treat aortic valve stenosis nowadays. In conclusion, is that transfemoral TAVI have proved to be an alternative to surgery across the whole spectrum of clinical risk. This is the same was what was known before 2017 in high-risk and intermediate patients. We can make this risk calculation take away and say in all patients, our all surgical risk spectrum TAVI is alternative to surgery. And the second conclusive point is the TAVI new gold standard for treatment of elderly with severe aortic stenosis. Not yet, but it seems that it's very likely in this few years. In the next few years, it will not be surprised when we faced with new iteration of guidelines saying that in patients above 75, TAVI is the first choice to treat aortic stenosis, and it was not feasible consider the old gold standard, which is surgery. Okay, then when doing TAVI or considering TAVI, what would we choose? Which device? Before deciding that, which devices do we have? We have on the market plenty of devices. It could be implanted. All devices or which you see in the diagram have CE mark approved for implantation in the patient. We have two devices, the balloon-expandable Edward prosthesis, and this photo shows the last generation of this device, the balloon-expandable Sapien 3 Ultra prosthesis, and the self-expandable Evolute prosthesis. These two prostheses have randomized controlled data trials comparing outcomes to surgery. And in every TAVI center, one of these is the workhorse for the TAVI. As it's to say, in every TAVI center which performs the procedure will have majority of cases performed with either of these two. In some centers, both. Much centers make like one-to-one, we make one of this procedure that they keep their learning curve and their experience curve high for both procedures. The other procedures, they are also approved for implantation in patients with severe aortic stenosis in various European countries, but they lack direct comparative trials to the aortic valve surgery. For every prosthesis, there are feasibility data showing feasibility of implantation in humans with safety endpoints that say procedure is safe and effective. And for some of these prostheses, there are data comparing the performance when one of these two both prostheses, which are the main tool TAVI teams use for implantation. This doesn't answer the question, which prosthesis should I choose when I haven't decided, or we have decided with the patient we will undergo TAVI. Which prosthesis? It's a very complex question. The classical answer is you choose what you're familiar with. You choose the prosthesis you can do. And we choose the prosthesis your team has very good experience with, you feel comfortable when you work with this prosthesis. But TAVI is being performed in excellent centers. They have like 200 procedures per year, and it's not uncommon that a center has operators who perform 2-3 prostheses with a very good result in everyone. Then comes the second choice is anatomical factors. To be considered anatomical factors regarding the vascular axis, anatomical factors regarding the annular size of the patient, left ventricular outflow tract diameter, aortic root diameter, the height of coronary arteries, distribution of the calcium in the annulus. Every center has like criteria for which patient which prosthesis would optimally, or we expect that optimally perform this patient. There are also simulation programs like Framentio, which we can expect when we implant this or other prosthesis, how would it perform in the anatomy we see in screening diagnostics. So anatomical factors are important for inclusion of the prosthesis. However, with advanced technologies, lower profile introductory catheter systems, most patients are eligible for every prosthesis you have. So most patients, and we were not thinking about extremes of body size, very low body size or very high body size. Most patients would be eligible anatomically to every prosthesis you have. Pricing is an important factor. It will be not mentioned, but it's an important factor. At the end, we are getting a qualified budget for implantation of the prosthesis. And this means when this prosthesis costs the hospital more money than the other, then its profit in hospital is less when we implant one or the other prosthesis. So financial aspects play a role, not very much, but they do. And it's always, it's like intervention, coronary intervention, TAVI. It's like there is science, there is data for each prosthesis, there is my experience, but there is the art. It cannot be 100% answered with trial data. I can say trial data say this one is better for this patient, it's okay, but I have my or the interventional team has their own point of view for each patient. It will be individualized. It's many factors to be considered. It's nevertheless, it's important to look at the literature, and it's important to look if the scientific evidence, or we have specific scientific evidence in favor one or other prosthesis and special situations, to consider it and to optimize the outcomes for our patients. We are in the era of personalized medicine, which every procedure can be planned beforehand. Before we do every step, we have plenty of information, about every patient, functional, anatomical. We have simulations program, how would every prosthesis perform, what to expect, and if we could personalize our choice to the patient, we may further optimize our results. So do we have data to support the choice of one or other prosthesis in specific patient? We have this in coronary artery disease, we have this for stents, right? Since years, we have every now and then a new trial which compare performance of this stent against other stents in various population with risk population, various anatomical constellations. These type of data are still scanty in the trial, but they are appearing. They are starting to appear. Here is an example for a trial, randomized prospective trial comparing lotus valve. Lotus valve is this one. It's methanol frame, mechanically expandable valve. A valve which can be retrieved, repositioned, and only when the interventional cardiologist happy with the result can release the valve and the valve is implanted. This valve was compared lately against 4 valves in a randomized prospective trial with 2-to-1 randomized fashion. The primary endpoint was all-cause mortality at 2 years and all-cause mortality.
كريم أنا I don't like to interfere بس إحنا قدامنا يعني few minutes كنا عايزين نفتح الأوبن discussion معاك فحبيت أديك نوتس بس لو سمحت.
قدامي قد إيه؟
إحنا مفروض السيمينار ده مدته 60 دقيقة فإحنا قدامنا كده حوالي 6 دقايق.
Okay, I will make it short. In this trial comparing lotus with 4 valve, based on characteristics of the patient who's the classical population over 80 years, intermediate risk patients, the outcome in 2 years was comparable. 4 lotus valve was non-inferior to 4 valve at 2 years as the primary combined endpoint, and in subgroup analysis of the secondary endpoints like stroke, disabling stroke, they were performed comparably. Nevertheless, pacemaker implantation with lotus valve was higher than 4 valve, which 4 valve is also notorious for high pacemaker, thermal pacemaker demand after TAVI, and lotus valve performed worse in this point. In another comparable trial, 2 prosthesis was Celitis accurate neuroprosthesis with SAPIEN 3. It was a non-inferiority trial. It will look at results at 1 year, but what we have is first analysis of 30-day outcome after the prosthesis. The primary combined point were all cause death, stroke, life-threatening bleeding, major vascular complications. It's a combined endpoint for VARC2 safety and efficacy outcomes after death. The study was designed as non-inferiority study, and they have postulated that accurate neo will be non-inferior SAPIEN if a difference between the combined endpoint difference where did not cross the margin of 7.1%. They did not meet that. In their analysis, the accurate was inferior to SAPIEN 3 in the primary endpoint. And in secondary analysis of superiority, the SAPIEN 3 was superior in outcome to accurate neo. There are relatively new prostheses. Interesting would be how perform core valve, or how do self-expandable evolute core valve perform against tapial. I apologize for time, but this is a very interesting study. It's comparing retrospective analysis of data from France. All TAVIs performed in France. The majority of these procedures were performed with either balloon-expandable iteration consortium or self-expandable core valve. We made a one-to-one propensity match, and we made also sensitivity analysis, inverse probability weighted match, and we asked long-term mortality after. The patients were, before matching and after matching, the patient characteristics they will differ. Only this in red after matching was a little bit optimized in design characteristics. In their analysis, they compared 5,900 patients in each group, and what they found that mortality with balloon-expandable prosthesis was superior in outcome to self-expandable prosthesis in regard in hospital mortality and long-term mortality and paravalvular leaks. This was true in propensity matched scores. This was also true in their sensitivity analysis, including inverted probability weighted score. This was true also in unmatched population. When they take all the patients without matching, the data were true. The survival curves for all-cause mortality and cardiovascular was similar, was separated early, and separation continues to 24 months. Closer look at this here. There is increased mortality after balloon-expandable prosthesis in 30 months, but there is, when we exclude this period, when we exclude the first period from this analysis, the mortality difference is not significant after this period and remains non-significant. What happens after 3 months of implantation is similar in both prostheses, but this early outcome, this early mortality difference between both, extends the results to the end. Further studies will be needed to explain this. I think they will be coming in coming years. We have tried in a single center trial, on a single center observational trial, to elaborate on this point, and we have postulated that maybe baseline patient characteristics may influence the outcome after implementation of either prosthesis. Short saying, balloon-expandable prosthesis is notorious for pacemaker implantation, high need for pacemaker implantation, and more paravalvular leaks when compared to balloon-expandable. And we postulated that if these outcomes were met in patients who are at baseline low ejection fraction or at baseline had poor left ventricular performance, maybe this would explain different outcomes in different prosthesis types. We have divided our patients, about 680 patients who undergo TAVI in our center. We have divided these patients according to ejection fraction in low ejection fraction, high normal ejection fraction group, and balloon-expandable and self-expandable group. We have in either group of ejection fraction no differences between those who undergo balloon-expandable and self-expandable prosthesis in every category of ejection fraction. And what about the outcomes? Aortic valve, it's like every study, aortic valve area was gradient was aortic valve gradient after implantation was lower with the self-expandable prosthesis. We had higher paravalvular leaks in self-expandable prosthesis. We had higher incidence of pacemaker implantation after balloon-expandable prosthesis. Overall mortality was numerically higher in self-expandable prosthesis, but statistically non-significant in the whole study population. overall mortality was higher in patients with low ejection fraction. When we look at the overall mortality in every ejection fraction category, we see that in patients with present ejection fraction, there was no outcome difference in either placebo group. But in patients with low ejection fraction, the self-expandable procedure performed much worse than the balloon-expandable procedures. In multivariate analysis, this could not be explained by paravalvular leaks. This could not be explained by more need for pacemaker implantation. It seems that the procedure design play a major role in outcome in patients with low ejection fraction. The study is retrospective, observational. It needs further research, to maybe prospective research, to elaborate on it and to look closer what could be responsible for this outcome difference. It's significant for the patient, but because when we confirm these results or explain them, we could further have further optimized outcome patients by simply choosing the right device for the right patient. I have planned another section. I will not go through it. It's my fault that the time ran for me. I would like only to show only 2 slides, and interesting follower could look for the trials which elaborate on the slide. This is our classical teaching curve about severe aortic stenosis. Severe aortic stenosis becomes a disease with significant bad outcome when symptoms develop. This is our classical teaching. This is what we all know. There are some trials with some new evidence which put this paradigm in question. Herkang from South Korea have performed a prospective trial, early surgery, conservative treatment, asymptomatic severe aortic stenosis. Elegant trial, run in a 5-year period. It is difficult to recruit this patient. The data is presented that early surgery had clearly better outcome than conservative treatment in this patient. Notably, conservative treatment patients that they became guideline treatment of stenosis. They were not treated conservatively over a period of 6 years. They were operated upon, but the surgery was performed only when symptoms developed. Early treatment of severe aortic stenosis was superior to surgery in this patient population. Another trial which we don't have time for this, but it's very important because it's a very big data. As an example of big data in medicine, echo reports from whole Australia were collected. From this echo reports, we collected data about every grade of aortic stenosis. Ended with 250,000 patients with aortic stenosis. And we linked the data of these patients, or the investigators linked the data for these patients with mortality records of Australia, and they categorized the complete echo parameters of the patients were published, and categorized the mortality according to grade of aortic stenosis. Not surprisingly, patients with severe aortic stenosis had a higher long-term mortality than those with those they did not have. We don't have symptoms of this patient. We consider only severity grade of the disease. And it's not surprising that severe aortic stenosis had bad outcome. Surprisingly, that the patient with moderate aortic stenosis and moderate aortic stenosis, when we see this slide, it was NPI, it was the gradient 20 millimeter, mean gradient 20 millimeter mercury, or peak velocity tri-meter per second. They have not much different outcome for their severe aortic stenosis counterpart. It seems that the disease is not benign, so benign, and it seems that the disease also not in early stages, in middle stages, is not so benign as we consider it. So are we going to treat these patients? Maybe, maybe not. What we know that we don't have such good outcome as normal population, but we need further studies elaborating on this and showing that if we treated these patients, they will have better outcome. Few trials are underway. This is another trial which questions asymptomatic or severe aortic stenosis surgery or not. A similar trial will test TAVI in asymptomatic patients. And this one is looking at patients with impaired ejection fraction, moderate aortic stenosis. What we, if treated moderate aortic stenosis in this patient, would we have a better outcome? Results of the trials are not awaited before the next version of guidelines. The next guidelines are about to be released next year. The result of these trials will wait to end next year or beginning of 2022. But I believe that they will change our look to aortic stenosis in the very near future. I apologize for the time delay. I thank you for your patience, and I hope, yeah, I am ready to question. I hope it makes work not too boring.
Thank you, Dr. Karim ElChilali. We enjoyed your presentation. Actually, I'd like to reintroduce you to our younger colleagues. دكتور كريم الهلالي أحد طيور اسم القلب والأوعية الدموية القصر العيني، مهاجر إلى ألمانيا. هو حصل على الماجستير أمراض القلب من القصر العيني، وكمان عمل رسالة الدكتوراه، وهو التخصص الدقيق بتاعه التافي والأورتيك ستينوزس. كمان هو زوج دكتورة هبة، أستاذ مساعد قسم أمراض القلب. طبعا عشان الوقت خلوني ان احنا نخلي الدسكشن مختصره. انا عندي سؤال او سؤالين سريع، وعايزين اجابه سريعه يا دكتور كريم لو سمحت. يعني هنخلي الاسئله جاست كده هو شورت كومنتس لو سمحت. السؤال الاول بخصوص اللو بريشر لو جريدينت اورتيك ستينوزس. هل في انفستيجيشنز بتتعمل ولا في مدرسه بتقول لك وات ايفر الجريدينت العيان ده هو ديزيرف تافي؟
Both are true. Short answer, both are true. Some centers make the dopamine stress test, look at myocardial reserve. Others say when it's severe aortic stenosis, whatever the gradient, they profit. There is evidence supporting both. There is also both schools have enough supporting evidence. Individual decision, mostly they will get that. Mostly the patient get that.
اوكي. السؤال الثاني، في لسه still a place for aortic balloon valvuloplasty. I mean, sometimes we are confronted with patients with cardiogenic shock resistant heart failure, even pregnant ladies with tight aortic stenosis. Are we justified to do only balloon, knowing that the mortality is 6%, the complication is severe 6% extra?
Depends on where are you doing this. If TAVI is available on site, if TAVI is available on site, we do emergency TAVI because it's the same step as well. Same steps, much better outcome. Mind you also that in the early years we had balloon valvoplasty in every TAVI patient, and then TAVI after balloon valvoplasty. New trend in TAVI is implanting the valve without balloon valvoplasty for. The first step is implantation of valve directly. So if we are dealing with this patient, with this emergency, as a cardiogenic shock in severe aortic stenosis in a TAVI center, most probably she will undergo emergency TAVI. If we are in a center, not a TAVI center, and the transport of this patient is not possible, there are data that balloon bridging is okay. These data are not a little bit old data, but they are valid. Then
we are justified to do this procedure.
We are justified, but like bridging.
آخر سؤال, severe coronary artery disease in the presence of severe aortic stenosis. Patient is indicated for both TAVI and coronary angioplasty. Which will be your policy?
We discussed this in our team, where consensus should be made. Are we going in direction TAVI or are we doing surgery? If surgery will be done, they do everything surgery. They will do bypass on aortic valve. If we do TAVI, we treat all significant lesions before the procedure, and we treat coronary artery disease first. Significant left main LAD lesions should be treated. Intermediate lesions, there is very smooth. Could be done much more. And after treated significant LAD, significant left main lesions, patient undergo in the second Detsung, in a second procedure becomes
no controlled trials about doing it simultaneous or one PCI before or after?
There are data for PCI before. It is safe and feasible. Simultaneous, it's individual decision. If we do simultaneously, it's individual decision. But basically, one would like, if it's not emergency, one after another.
Okay, thank you, Karim. I will leave the mic to my colleagues. دكتور ياسر شرف معانا ودكتور رضا دياب ودكتور ياسر بغدادي. اللي يحب فيكم يتفضلوا.
هو دلوقتي انا سايب كل الناس اللي عايز يعمل انميوت لنفسه ممكن يعمل انميوت. هو اعتقد دكتور رضا كان عنده بعض الاستفسارات، فاتفضل دكتور رضا.
السلام عليكم جميعا، و احنا مبسوطين جدا ان شايفينك يا كريم معانا. وكان ليا تساؤل، what are the explanation for such a higher mortality in transapical TAVI? Is there any predictors of mortality in this subset of patients or not? Second question is, the last two slides بتوع الأستراليان registry دي اللي مبينة إن mortality even في mild aortic stenosis in comparison to normal is significant. This means إن إحنا هنعالج mild aortic stenosis كمان؟ ولا دي extrapolation كبيرة قوي يعني؟
أبدأ بالثانية.
طيب.
حقيقي statistically المورتاليتي في الأستراليان داتا أو في المايلد aortic stenosis is significantly higher than normal. But I don't. The authors did not believe that it will change. It will lead to clinical change in treatment policy. I will shift to this slide. This is the curve for normal mortality curve for normal, mild, moderate, and severe. Mild is significantly higher mortality than moderate than normal, but if we compare the mild to severe, we will also see significant difference. What is interesting here in this curve, that if we statistically put these curves together, moderate and severe, there will be no significant difference in outcome. We could say that severe aortic stenosis, according to our current guidelines, will not all patients with severe aortic stenosis need treatment. According to current guidelines, they could be under watchful waiting and then undergo surgery or TAVI when they symptomatic. But there is no guidelines that advocate management of moderate aortic stenosis. This data show that this disease in this stage, severity stage, has similar outcome to severe. So in the next few years, maybe I don't know. Maybe if we show that specific subsets of patients with moderate aortic stenosis benefit from early intervention, maybe we will see interventions in moderate aortic stenosis in the less invasive way, as unlikely surgery. Mostly it will be a TAVI procedure in moderate aortic stenosis. If it will be justified, it will be certainly justified in patients with underlying myocardial disease, underlying cardiomyopathy and aortic stenosis, and it will be like unloading these patients in a fashion similar to ARBs or angiotensin-converting enzyme inhibitors, which decrease after load. Also, when we have moderate aortic stenosis and we could do it away, we are unloading these patients. Theoretically, it could function, but we need evidence. Evidence is not there, it's coming. This was my answer for the second question. For the early question regarding transapical TAVI. Transapical TAVI from beginning on was an option for patients where transfemoral was not possible. Transfemoral was not possible in patients with extremely advanced vascular disease. We had at the beginning of TAVI, we had a very big introducing catheter. It was not easy to perform the procedure in every patient. We had very high incidence of vascular complications, occlusions, and bleeding complications. And if the procedure itself was done or performed in patients who are prohibitive or very high risk procedure. That means if we don't do TAVI, it will have nothing. So it was like backup procedure. Okay, we could do it transfemoral, we do it transapical. Showed good results in comparison to doing nothing, but these patients were sicker than transfemoral patients and they had worse outcome. So why transapical patients have worse outcome? Because they are sicker patients. But as TAVI goes on, there was TAVI was performed from cardiologists. Transapical was performed from surgeons. And there are surgical centers who make transapical TAVI as alternative to surgery in their patients. So we had growing data at early years that transapical increasing transapical performance. The surgeons had the feeling that this procedure is less invasive than surgery, which is true. But accumulating evidence showed that also in patients, if we say we take transfemoral transapical and make a comparison, the outcome is always better in transfemoral, and it may be explained by myocardial injury and myocardial stunning in patients who undergo transapical. In transapical TAVI, we need to pierce the left ventricle. We need to sew the left ventricle after the procedure. MRI studies showed this increased myocardial fibrosis after transapical TAVI in compared to transfemoral. I would say that myocardial injury is one of the factors that make transfemoral more elegant than transapical. It also goes with the principle of TAVI, the very early principle of TAVI. If we can do it gentle, we may do it in very high risk patients. And gentle is don't touch the heart, make the valve, put the valve in, go away, and possibly don't touch the heart. No much research is going in this direction now, because every TAVI trial, every current TAVI trial is concerned with transfemoral TAVI. But we can extrapolate from studies which show that outcome of patients with pacemakers, without pacemakers, outcome of patients by aortic regurg after TAVI, no aortic regurg, every step which leads to increased myocardial injury has less favorable outcome than steps which include less engagement with myocardium.
شكرا يا كريم، شكرا، وربنا يوفقك يا حبيبي.
دكتور ياسر شرف يحب يدينا كومنت. دكتوره وفاء.
لا انا احب اسلم عليكم جميعا واسلم على كريم وعلى هبه. enjoyed البرزنتيشن في حدود خبرتي بالتافي. ربنا يوفقكم ان شاء الله.
وفاء حضرتك وحشانا كتير. شكرا لحضرتك.
دكتور ياسر شرف. اي حد يحب يقول كومنت. دكتور احمد سمير انا شايفه معانا.
لو ينفع اسال سؤال تاني ولا طلعوني بره؟
طبعا يا رضا، انت تنفع تسال كل الاسئله، انت عارف يعني.
الله يخليك. كريم، دلوقتي انت بينت ان البالون اكسباندبل valves has a better outcome in comparison to the self-expandable valve. الكلام ده لحد 2015 مش كده؟ الترايل اللي انت الكومباريزون دي كانت لحد من 2012 ل 2015. هل في حاجه جديده بالنسبه للثيرد جنريشن فالفز زي السابيان الجديد والايفوليوت الجديد؟ هل نفس الريزلتس دي موجوده؟ انا معلوماتي ان البارا فالفولار ليك والنيد فور بيس ميكر امبلانتيشن في السيلف اكسباندبل ستنت النيو جنريشن 1 are markedly reduced, and even in البالون اكسباندبل الانسيدنس اوف بيس ميكر نيد زادت شويه عن السابيان القديم علشان الكف الجديده اللي اتحطت دي بحيث انها تقلل البارا فالفولار ليك، لكنها جت على at the expense of more need for pacemaker implantation. سؤالي بقى، هل الداتا دي في نيو داتا تبين في فرق فعلا بين الاثنين، ولا القصه بدات تبقى decreased markedly كمورتاليتي وايز؟
Okay. There are till now there are no prospective head-to-head comparison sapien evolute. Till now, this comparison are not there, and if in future there will be such comparison, it will be an independent trial, as it will not be investigator-initiated trial. As Sapien will not initiate such a trial, as Edward will not, and Medtronic will not initiate such a trial. All prospective trials which we have for TAVI till now, apart from one motion trial, they are all investigator-sponsored. The data which we have about outcomes from Sapien and Evolute are observational data and are indirect extrapolations from this randomized trial. In the particular study which done in France, this is the France-TAVI Registry. This is the continuation of the initial France-2 Registry, TAVI Registry of France. They put in every TAVI procedure done in France. What they compared the data from January 13 to December 15. And they make this comparison when they propose the matching. They made the comparison within 3 months time of the procedure. This means they could only compare balloon expandable with self-expandable when both procedures were performed within 3 months time. We could not compare a TAVI procedure done with balloon expandable in 2015 with core valve procedure 2013. This was not allowed. One of matching criteria was that both procedures were performed within 3 months time frame. And this is because over the time, every prosthesis was improved. There was improvement in every prosthesis upon the time that they wanted to perform a fair comparison. They show that in the early year, this is a retrospective. This means there was no influence of investigator on what prosthesis would be made. Every center was deciding for patient what would I implant. They show that regarding balloon expandable, 50%, 50%. So in early year, in the late year, the incidence of implantation, 50% of patients were becoming balloon expandable in centers which implanted balloon expandable. On the other hand, in centers implanted self-expandable, in early years, 60% of their patients were becoming self-expandable, and in the late year, 36%. The half of the patients were shifting for the other. This was in a retrospective trial. We cannot say why is so, but I believe this was the sensitization of interventional cardiologists. Paravalvular leaks are a problem. We have a prosthesis which with more paravalvular leaks, when I can have a better choice with regard to what I will do. In this particular analysis, they made a sensitivity analysis or made a secondary analysis comparing the outcome in every generation of the valve. They made secondary analysis comparing Evolute to Sapien 3, core valve to XT. The outcomes were going in the same direction, irrespective of the valve generation compared. Sapien 3 Sapien 3 has more pacemaker after adding that. I personally don't have that, but we shall see. We should see. Personally, what I know from Sapien 3, if you don't have pacemaker in first 24 hours, you will probably ending without pacemaker. If you don't have indication for pacemaker 24 hours after implantation of your prosthesis, you will probably end without pacemaker. In Evolute, this is another story. You can need pacemaker weeks after implantation. So, I still believe that balloon expandable is more predictable in this regard.
Thank you very much. شكرا يا كريم.
طيب اعتقد كده بالتالي مفيش حد عنده اسئله تانية. احنا متشكرين جدا يا كريم، بصراحه مجهود خرافي منك، يعني حضرت جامد ومبسوطين جدا ان شفناك، وسلامنا للدكتوره هبه برضك. وبالتالي كده نقفل الميتنج النهارده. متشكرين جدا.
قبل ما نخلص، انا احب اشكر دكتور محمد عبد الغني، احب اشكر اساتذتي في الاسم جميعا، احب اشكر اخيرا اولا واخيرا الدكتور ياسر بغدادي لمساعدته الجامه في انجاح البرزنتيشن، لمساعدتي في التغلب على العقبات المهوله اللي كانت عندي فيما يخص